Bismillahirrahmanirrahim. So now we have to start the part of this theme of fragmental integration was regarding the control by certain endocrine tumors, and among them or certain endocrine organs. And in this view, there are some pathologies which we have to discuss. Pancreas and or you can say kidney and pancreas is a main organs which we are dealing with in this block, especially when we are taking from M1 to M2. We take some of the pancreas before histology and other things, and now we will be taking some pancreatic pathology. So pancreas, you can go through this scenario. Okay. Yes, Jihad, read it.
A young male presented in emergency with worst pain of his life in the epigastrium. Pain is constant and intense, and it's referred to upper tract and bowel sound are absent. What laboratory tests are needed for diagnosis? What is the differential diagnosis?
Doctor, I have a question.
Yes.
In the last exam, there was a question like this, 26. Was what the worst thing you can see it
Prognosis.
in the prognosis? We didn't take something like that in your slide, and I don't know what's the answer, right answer.
Yeah, actually, you are like the kindergarten students. If they tell you ABC, then they can do ABC. If you don't know it is from Z to A, then there will be a problem. So
Yeah, but
when we are taking the repetitive progressive disease, you can see that we also verbally discussed why it is called repetitive progressive, because the name is telling us that it is the most frequent disease which ends up into sudden renal failure. The most important cause, or the one cause which is causing sudden renal failure, is repetitive progressive among liver fibers.
Okay, what about chronic inflammations?
Yes, chronic inflammation, it is, we say what is something which is there.
Mhm.
Now, chronic inflammation will take many years, 10 years for a patient to have a bad prognosis. While we are talking that what we'll see under the microscope, so we can see that something which is which is very horrific for the patient. When we tell to the patient, well, it's something which is very bad. So we already discussed that rapidly progressive is that, and one of the most important histological feature of this was crescents, hilal.
We know this.
Okay.
Crescents, yeah.
So even the previous question which was dealing with that, it was already to tell that it is related with crescents. So actually it was an indirect question, so that instead of asking, if I say what is the worst disease and I will name the disease, obviously among all of them you know that repetitive progressive is something like that.
We wouldn't
So it
know.
was a double question which was needed.
Well,
First you have to go through-
if you put the other question, no one will answer it.
Maybe
Because you didn't write it in.
Yeah, this is the problem with the writing.
Yeah,
Everything should be written.
we are studying from slides and nothing was
If you are
written.
just studying from the slides, even if it is discussed during the lecture, even if it is discussed, but even if you are just thinking that with slides you are a lama, you can go anywhere, or Dr. Mudassir is teaching you, it is the whole of pathology. It's
Yes.
never possible.
If anyone asks me, I will say, Dr. Mudassir, teach me.
Yeah, you can tell. But the problem, Dr. Mudassir is not perfect. And I cannot show in this 30 minutes, 40 minutes when you have to go to washroom multiple times and a lot of things have to happen. 15 minutes I have to wait, 10 minutes you want to go early. And in the remaining 35 minutes I cannot cover the whole pathology. Okay? If you give me time, you stay here, we can discuss each and every part, everything which is written in the book. Now in this short time, we can discuss the things in bullets. I cannot print the whole book in presentation. Okay, and give it to you. Okay, now this is your book. Read it in your whole life. Always presentations are like that, where you have to discuss the main things, and you have to supplement it with, not only with presentation, but also with your book, which is textbooks. Nobody can challenge it. Okay. So the worst prognosis here, what do you think? What laboratory tests are needed for diagnosis? MRI? Possibly MRI can be done, but laboratory means something which is done in the lab. A blood test, for example, or some other biochemical test. First, do you think what is differential diagnosis here in this case?
Pancreatic cancer?
Bowel sound is absent, so
So, Could be
Yes.
obstruction.
Could be obstruction.
The ampulla of or neck of pancreas cancer, which will obstruct both the bile duct and the pancreatic duct.
Yeah. These are different possibilities. So when it's called differential diagnosis, not talking. Okay. This is last one. And please come here, shift here. Don't waste my time. No, beside these four guys, distribute. This one, second, third, fourth row. Okay, have a seat, one between each. Move, bro. Okay, already I have less time. If you are not letting me complete it, the presentation will be you. I will not able to complete. There is no more lecture which I have with me. Okay. So, when differential diagnosis is there, you can think about any possible thing. Okay? And the best way to do it, that you will think that most likely and the other possibilities. Okay, for example, here you can see it could be pancreatic cancer, it could be gallbladder cancer, it could be intestinal obstruction. So, possibilities in differential diagnosis could be very wide. But you should see what is the most focusing thing. So maybe you can say there is something related with pancreas. Now what that can be,
Refer to the upper back.
the upper back. It is something which is also one of the very common. If it is something gallbladder, then this is shifting to the tip of the shoulder. But this is something which is in between the scapular region. This is the typical sign of a disease. What is that? We will come, and then we will also know what are the laboratory tests which are needed. So keep these questions in mind. And afterwards you will get answers of these questions. So this is the normal enzymes which are secreted by pancreas. You already know about them, and these are this is the histology. We will not waste our time. You have already taken these things before. We will discuss pancreatic diseases. So it could be congenital, it could be inflammatory and neoplastic. Nearly all organs we discuss pathologies in this way so that we can differentiate between them. So this is the congenital one. Agenesis. What is the meaning of agenesis?
No pancreas.
No pancreas at all. Pancreas divisum. So failure of two ducts to fuse. What happens that embryologically there are two buds. One is called dorsal bud, one is called ventral bud. These two buds are very in proximity with each other, and they have separate ducts which are opening into duodenum. During the process, these two ducts or these two buds, they fuse with each other, and their ducts also fuse with each other.
Yes.
Sometimes, in some persons, these two ducts, they don't fuse. Rather, they are, even the buds are fused, but their ducts remain same. They're different, and they are entering into duodenum at two different places. So this is called pancreas divisum, divide. So their ducts are divided now. And it is very common. Then annular pancreas, you know that a kind of, the head of pancreas is encircling normally the duodenum, part of the duodenum. And sometimes it is making so much encircling that it causes complete blockage at the duodenal level. So this is called annular pancreas, when the pancreas encircles duodenum completely. And it can lead to one of the cause of intestinal obstruction. And it could be congenitally present. And also very common is ectopic pancreas. Pancreatic tissue can be seen in Meckel's diverticulum. You know about Meckel's diverticulum? Okay, you have got this before. It can be seen in sometime in part of the stomach. It can be seen sometime in the intestine, sometime ovary. So ectopic tissue or ectopic presence of pancreatic tissue, not the whole pancreas. Few buds of pancreas can be seen anywhere else in the body. Then this is the normal duct. We are talking about that the pancreas, these buds are fused now and their ducts afterward. This is obliterated, and rather this is also coming and joining with the same. You already know that this is gallbladder. This is the right hepatic, left hepatic, common hepatic, cystic duct combined with each other to make common bile duct. This common bile duct combined with pancreatic duct, and ultimately they open at ampulla of Vetter. What is the sphincter here?
All these.
All these sphincters. So this is the place where they are going to enter here. So pancreatitis, the first inflammatory pathology, very, very common, is pancreatitis. It could be acute and chronic based on the duration. Acute pancreatitis is very, very severe condition. Rather, it is one of the very severe medical emergency. A lot of people, young people even, they can die without any complication, without any significant diseases just because of pancreatitis. I have seen many cases during my residency when people, they were looking normal. They have just few balloting and other issues with some pain, and then it is relieved, and suddenly they die because of severe pancreatitis which they develop. So acute pancreatitis and then chronic pancreatitis, which have some calcification, some pseudocyst. Acute pancreatitis, what could be the consequences? Naturally speaking, we should go through etiology first and then complication. But in this slide, we will let you know the severity of pancreatitis, that what it can cause, what are the consequences, so that you can know why this disease is important to know, and then we will come to etiology and the pathogenesis. So acute pancreatitis can cause multiple organ failure, it can cause shock, it can cause ARDS, it can cause renal failure.
What's the ARDS?
Oh yes, it can, yes, acute respiratory distress syndrome in the respiration, breathing and circulation.
Again?
You have taken this ARDS, acute respiratory distress syndrome. Then DIC, which is the systemic coagulation, small microclots throughout the vascular system, pancreatic abscess formation, pancreatic pseudocyst formation, even it can block the duodenum obstruction can happen. And the chronic pancreatitis, it is usually having like this, can have pseudocyst, not the true cyst. We will discuss what are these pseudocysts. It can cause the blockage of the ducts of the pancreas, or sometimes the bile duct. It can cause malabsorption and steatorrhea. Can you know why malabsorption can happen in pancreatitis?
Because we need the lipase enzymes to also.
Yes, so these enzymes, when they are not secreted, they may cause malabsorption. So the difference between acute and chronic pancreatitis can be on these. That in chronic pancreatitis there will be significant malabsorption, while in acute pancreatitis, to start with, there will be no malabsorption. And even it can cause diabetes mellitus, secondary diabetes. So one of the important cause of diabetes mellitus or secondary diabetes mellitus is pancreatitis. This pancreatitis is actually damaging the enzymes which are leaking out. For example, amylase, lipase, they start to digest their own tissues, own pancreas. And when it happens, it can also damage the insulin cells, the beta cells, alpha cells, and ultimately so much damage can happen that they become insufficient to produce excessive or normal insulin, leading to diabetes mellitus. Okay? So these two are very important differences between acute and chronic pancreatitis. Number one, malabsorption. Number two, it can cause secondary diabetes mellitus. And obviously pseudocysts are also more common as a consequence of pancreatitis. Then, what are the etiological factors? Now we are talking about acute pancreatitis. This is something, the clinical features. As I told you before, abdominal pain, which is severe abdominal pain, extreme emergency situation. It has a high mortality. Death rate is very high with pancreatitis. So what is the most important laboratory test? I will just come to that. Etiology, in the foreign setup where alcoholism is very like a normal drink, so alcoholism is the most important cause of pancreatitis. And in our setup where people are less prone to take it and who have a lot of inclined to take fatty meals, so there are chances of getting a lot of gallstones or bile stones. So these stones sometimes slip from bile duct into the and they can come at the level of where the bile duct is combining with pancreatic duct and block that. So once it blocked, so the pancreatic secretions, they cannot enter into the duodenum, rather they leak out into the pancreas itself, causing autolysis, and can also leak into the abdomen, causing severe pancreatitis. So the cause of excessive damage or mortality is actually leakage of the enzymes, the lipases, the amylases, and these are digesting proteins, these are digesting fats. All our membranes, they are made of proteins and fats and lipids. So you can imagine that everything is digested by our own enzymes. This is called autolysis, breakdown of our own tissues. That is done by the by the enzymes which are released after blockage. So these two are the most important causes. So if I say causes, and you are reading a lot of infection, gene, other things, but you are not mentioning these two, your marks may be cut. So when we are talking about three causes, then at least you should have these, and then you can choose any one of them. Okay? So always try to know what is essential to know. What are the most important things to know? That would be important 3 or 4. And then you can remember. But what is our brain usually? That we may incline to forget all those, and out of these we will remember very small things, and we can, it's normal human brain that they are more inclined to less important things. But I'm telling you, these are the most important things. Medications, hazard diuretics, sulfonamides, they can cause these pancreatitis to happen. Sometimes other etiological factors which are confirmed, not very much confirmed, but still they can be hypertriglyceridemia, which can lead to cholesterol stones, obviously, hypercalcemia, more chances of stones. So it is actually coming to cause more gallstones, and they can cause the same pathology. Acute ischemia of the blood supply of the pancreas, it can be one of the reasons. Trauma, especially blood trauma. Somebody during soccer, playing football, so if suddenly they got a very huge blow at the level of epigastrium, the two organs which are very much likely to be damaged by these kind of injuries, blunt injuries, or usually traffic accidents, are the pancreas and spleen. So these two are which can cause immediate emergency, very severe conditions. So we should always suspect that it can be damaged in case of very severe blood traumas to the abdomen. So if they are saved, then no problem, we can manage slowly with conservative management. But obviously you need to get analysis, you get to get ultrasound, CT scan to get the real situation. So genes, sometimes they believe those people who have these two genetic mutations, they are more likely to have pancreatitis. It could be idiopathic, no important cause, no known cause in 10 to 20% cases. Even mumps, Coxsackie virus can cause this. Parasites like Ascaris and Clonorchis sinensis, Ascaris lumbricoides, they can cause acute pancreatitis, and the most important cause again, this can lead to this or some, it is pancreatic depression. So what is the most important lab test?
Amylase.
It could be amylases, which is a normal product of pancreas is amylase, lipase. So obviously these enzymes can be very much helpful in cases of pancreatitis also.
So look for enzymes.
Yes. So we should first always go for amylase and lipase.
Why didn't we use C protein?
Yeah, C-reactive protein is non-specific. In any kind of acute infection, it can be raised. So you can tell with surety that there is an itis, but you cannot say that this is pancreatitis.
How about insulin C peptide?
Yes, insulin C peptides can be useful when the islet cells are damaged.
If there is obstruction.
If there is obstruction and if there is damage to the islet cells. But if there is no damage to the islet cells, it may not be. If there is only the exocrine pancreas which is damaged, you may not get any idea with that. Okay? So to get an idea of the exocrine portion which is damaged, you have to go for these two, which is the most important test you should know. And among them, the timing is very important. Timing. In the initial 24 hours, the amylase are raised. So somebody who got severe kind of pain here, and you want, and the episode started, like 12 hours, 13 hours, you can rely on amylase. But after 24 hours, the level of amylase, it is, a little bit less significant, and then the lipase levels are very much important. Okay, so after 24 or 28 hours, they say that the lipase levels would be very much helpful. But if you want to go for serum lipase in the initial 24 hours, you will not get result, because still they need time to get out of into the blood and tissues. Okay, so the first 24 hours, amylase is the best test, and even it will raise afterwards. But you can also combine amylase with lipase after 24 hours. But most important after 24 hours will be lipase. Then you can use the calcium levels. Mostly it is associated with hypercalcemias. You can use the CT scan, MRI, ultrasound. These visualization techniques can be used. Then just somewhere else. The morphology is not talking. So how this pancreatitis patient will have under the microscope will look like? There will be microvascular leakage which will cause edema. Okay, there will be edema, microvascular leakage which will cause edema of the pancreas, and you know that the lipase or amylase which are released, they must go for autodigestion. So the fat lipases will cause fat necrosis, and because this is an itis, obviously you should have acute inflammatory infiltrate. For example, which cells?
Neutrophils.
The neutrophils are most important in acute. So there is pancreas autodigestion by proteolytic destructions. The blood vessel destruction leading to hemorrhage. So sometimes the blood vessels, their proteins are digested by these amylases, lipases, DNases. So there is leakage or hemorrhage of the blood into the surrounding area. So you will see a lot of hemorrhage in the epigastrium region. And we can also have saponification. You know that soap, sabun, okay? So if you know that the consistency of sabun, because it contains a lot of fat, so again actually the fat, they combines with calcium to make a hard soap-like substances in the epigastrium. So at a lot of different areas where you will find these hard soap-like fragments. Actually, microscopically they are fatty acids, fatty cells, along with excessive calcium. So they combine with each other to make saponification. So you will find these fragments of these areas in many areas of tissues. Like this is pancreas, you can see a lot of necrosis and hemorrhage here. You can see these yellowish areas which are manifesting the saponification here. But the more damages is the head of pancreas. And when we go for microscopically, again there is a lot of sea of neutrophils. The protein will be digested. There is fat necrosis. There is hemorrhage. There is necrosis. There is acute inflammatory infiltrate with hemorrhage. The complications we already discussed. That there will be abscess. What is abscess?
Pus.
Accumulation of pus, and pus contains excessive neutrophils. The collection of dead neutrophils is called pus, and actually abscess is collection of neutrophils. Collection of neutrophils. So pancreatic abscesses, as you can see, the whole sea of neutrophils here. It can cause pseudocyst formation. What is cyst?
Cyst?
Yes.
Sac, yeah.
It's a sac, but every sac will not be called a cyst with fluid. With fluid, still it is not cyst.
I have
It's
two
just a
opening.
cavity with a fluid.
I have two opening without cavity. Or not opening in the cavity.
Then it is called fistula.
Fistula open in the cavity, I think.
Yes. The fistula, when it is when there is a cavity which is connected with two epithelial surfaces, then it is called fistula. And cyst is actually a wall-bound cavity which is lined by epithelial cells. So you should find epithelial cells, any epithelial cells here in the wall. But if you don't find any epithelial cells, and usually it is filled with fluid, so any cavity, a wall-bound cavity, as you can see here, there is a wall-bound cavity here. But you should also find on microscopic examination some epithelial surface, some epithelium in the boundary. If you don't find any epithelium, then it is called pseudocyst. Means it looks like cyst, but truly speaking, it is not cyst. So cyst should have a wall-bound cavity which is lined by epithelial cells and filled with fluid. Then it is called cyst. And fistula is when this gets
Open in the cavity.
opening. This is an epithelial surface. It gets opening into some epithelial surface in the abdomen, from here to the intestine. So it gets connection between these two. Then it becomes
Fistula.
then we can call it as a fistula. Okay. Then what is sinus?
Sinus is the channel opening between two surfaces.
Yes. Actually, the same cyst, when it gets communicated with the outer surface, because this is not connected with
Also
inside
fistula.
any epithelial surface. Rather, this is just a cyst. So when a cyst or an abscess gets connection outside with one epithelial surface, not with two, then it is called sinus, like pylonidal sinus. So some people, they have some cyst in this intermittent cleft, because those people who have excessive hairs, so sometimes these hairs stuck inside to make a cyst-like thing, and they got communicated outside into the anal canal. So it communicates with them. Then it is called pylonidal sinus. But once it communicates at one side with one epithelial surface and other side with other epithelial surface, then it is called fistula. For example, a fistula between trachea and esophagus, or a fistula between intestine and bile, or fistula between, in these we have two epithelial surfaces.
Two organs.
Two organs, or you can say two epithelial surfaces.
Two epithelial
From one to one. Okay? Even it could be same organs, for example, intestine to intestine. For example, cecum to ileum. So you develop a communication between them and connection between them, then it is a fistula. So there will be pseudocyst because it is making some cavity which is filled with enzymes, filled with hemorrhage and fluid and edema, but still it has no epithelial lining. That's why it is called pseudocyst. There are liquefied areas of pancreas. So pancreas is liquefied or autolyzed because of amylases and lipases and DNases. There is increased pancreatic enzyme inside the pseudocyst. And what we do to confirm, sometimes the pancreas level may not be very raised, the amylase and lipase, in the chronic form especially. So what we go, that by ultrasound or CT, we go directly into the pseudocyst and we aspirate the material, and then we check for laboratory analysis for amylase and lipase. And usually we find high level of amylase in this pseudocyst.
Doctor, pseudocyst, is it characteristic for the pancreas or can we find it in other organs?
Pseudocyst can be found in any other organ, but this typically found in pancreas. Pancreas is the most common pathology whenever we have pancreatitis, usually chronic, but even it can be seen in acute. Then it is most likely seen. But the pseudocyst can be seen because of in other organs also, besides pancreatitis. For example, some people who have excessive inflammation in the, for example, peritoneum, we may find sometime a cavity, pseudocyst-like cavity there. Sometime in the intestine, we can find a pseudocyst formation. So they are present. They are found in other areas. But this is the most common organ where you can find pseudocyst after inflammation. So lab assessment of the aspirate from this pseudocyst can be helpful, and we may find a lot of infection, and sometimes this pseudocyst can rupture and it can leak the enzymes and hemorrhage into the peritoneum, into the abdominal cavity, then causing severe peritonitis. Okay? So these were the important features for acute. Then we come to chronic pancreatitis. So definition of chronic pancreatitis, whenever there is long-standing inflammation, there is fibrosis. Remember the word fibrosis. So obviously chronic, then the duration is long-standing.
Long term.
Fibrosis is an important feature of any kind of chronic inflammation. And there is destruction of pancreas. So we find destruction of exocrine part of pancreas. The chief distinction from acute is the irreversible impairment of the pancreatic function. So in acute pancreatitis, the pancreatic function will be damaged, but it will be reversible. But once there is irreversible damage to the pancreatic function regarding the secretion of exocrine enzymes, pancreatic amylase, lipases, DNAs, RNAs, all these, when they are irreversibly damaged, then that is the differentiating point between acute and chronic pancreatitis.
Chronic reversible.
Yes, chronic is irreversible.
Chronic irreversible.
And acute is reversible.
But here,
Chief distinction from acute.
acute is irreversible.
No. Acute is reversible. Why we are saying that? How we can differentiate this chronic from acute? By irreversibility. If it is irreversible, it cannot go back to normal. It is chronic. Then the chronic pancreatitis, the most common cause is pancreatic duct obstruction by gallstones, by tumor, for example, carcinoma of head of pancreas, carcinoma of the bile duct, or any stone. Anything which is causing the bile duct obstruction or pancreatic duct obstruction, especially the lower point, then this can lead to chronic pancreatitis. There is chronic alcoholism. No talking, please. Come here. More. Please come. genetics, which we find. Khalid also, please, Khalid move. Jihad, now it will be your turn, okay? So the same mutations, PRSS and SPINK1, the same mutations they can be responsible. The same in acute also. They are not different. But they are not the major role players here. Not very major. They are found, they are
Doctor,
important risk factors.
all the characteristics like the acute. All.
Like acute. But here you can see that they are long standing.
Just for long standing.
The most
Yes.
important is alcoholism.
Alcoholism again, alcoholism can be the alcoholism in acute was very
Also,
significant. Okay. And again you will see that the idiopathic here is more. Sometimes
There was from
because
10 to 20
it
years
is 40%. And here actually the stone is small. It is slipped, but still it is not completely blocking as it happened in acute. In acute, it will come and it will completely block it suddenly. Here, the stone will be released. It will be stone. It will be small in size. It will allow some secretions to go and some will be blocked. With passage of time, there is walling of this stone. The stone gets bigger and bigger, and then one day, after many years, it becomes completely blocked because of infection, because of some inflammation, or some other pathology which comes on top of that. Then it becomes significant. Okay? So these are the risk factors for chronic pancreatitis. Microscopic examination, as we already discussed in the difference, that we will find a lot of fibrosis. These pink areas where you find a lot of fibers here around the tissue, that is parenchymal fibrosis. And typically we will find that the acini, normal acini will be, if you go to the first picture, it will be so much like this. And then in cases of chronic pancreatitis, there will be significant decrease. You can see here, only these are the areas. Rest all is fibrosis. Only few ducts, fibrosis, few acini, then fibrosis. A lot of areas will be there where you don't find the other, where you don't find the acini and ducts. So reduced number of acini and ducts are the important microscopic feature of chronic pancreatitis. There is variable dilatation of the pancreatic duct. So the pancreatic duct typically they can be variably dilated because of this chronic obstruction. So the secretions are building and building, making the ducts to become larger and larger. So it could be very variable depending on the severity.
What is this thing inside?
This is the secretions. The pancreatic
The
secretions.
stuck secretions?
Yes, the secretions start to stuck inside. It can also have some edema fluid. It can have also some
Bile
inflammatory
stone
cells.
also.
Yes.
Can be bile stone.
So a lot of things can be significantly.
Can we find chronic inflammatory cells?
Yes, obviously. In any case of chronic inflammation, even in this picture, you can notice here, these are the formation of lymphoid follicles. So the chronic lymphocytes, lymphocyte plasma cells, eosinophils, you can find, especially if it is because of parasites, like Escherichia lumbricoides, you will find a lot of eosinophils. If it is just chronic, maybe you will find lymphocytes and plasma cells. So the basic pathology which we discussed, it will remain the same. It will apply everywhere. Clinical features, obviously again the abdominal pain. However, the pain here will not be very severe pain as we saw in acute pancreatitis.
Acute is
It
so
will be
severe.
vague, sometimes coming, sometimes happening. So you say maybe it is heartburn, maybe you say it is gastric ulcer, or maybe it is heart pain. So there are many, but still it will not be very severe. It will be vague. Sometimes there will be no symptoms, nothing. On examination by CT, you will find a lot of calcifications. Why the calcification what do you find? Again, the same reason that the enzymes, the lipases which are released, they cause fat digestion, and the fat ultimately combines with calcium to become saponification. So you will find a lot of calcification typically in the pancreas in cases of chronic pancreatitis. There is the pain will be usually localized, but vague. You cannot identify the area, and it is coming, going. It's vague. It is having sometimes only discomfort, not typical severe pain, but it is usually at the same position. Very rarely, if it is become acute, then you will find it between the scapular cord. But yes, otherwise it will be limited to here. So there is chronic diarrhea. Now, amylase enzyme should be elevated naturally because of blockage. Why there is chronic diarrhea?
Digestion, it causes osmosis in the large intestine because there is steatory
Yes, actually this diarrhea is malabsorption diarrhea. Because these enzymes, amylases, lipase, they are not reaching into the duodenum, they are blocked in between. So a person is eating these proteins and fats and carbohydrates, but still he is not or she is not able to digest it completely. So this can result in stasis, staying of these things inside the lumen of the intestine, and it sucks the water from the surrounding area, so it becomes bulky, and a person is losing a lot of proteins and fats and other things. So this leads to chronic malabsorption diarrhea, as you see in celiac disease, as you see in other malabsorption diseases, you will find here also. So high likelihood of pseudocyst. So you will find a lot of pseudocyst formation, more in cases of chronic pancreatitis. So sometimes the pseudocyst can be very big. What is this on?
Liver.
Spleen.
It is spleen actually. So the tail of the pancreas actually having such a big cyst that it can even stuck to the spleen also. So this hole is a big pseudocyst formation. And whenever you suspect pancreatitis, remember, no, don't open the abdomen. You think that it could be intestinal obstruction, and if you open the abdomen, a person who will die after 5 days can die within 1 day.
What?
Why? Because once you open the abdomen, you are making him more, what you should say, more prone, more susceptible to, his immunity is compromised. His metabolic derangements are compromised. Once you make a big surgery, this laparotomy is a very big surgery. It takes a lot of mortality by itself. So I know a person thinking that this is gallstone, or a person who thinking it's intestinal obstruction, they cannot find anything on CT and MRI. And they open it, and once they saw a big pseudocyst in the pancreas, they find a lot of hemorrhage in the pancreatic area, they say, oh, I have done a mistake. So they just drain it and they stitched it. But we saw that the patient
It's
died
not,
within 1 day.
it's not treated?
Yes, exactly. It is very difficult to treat pancreatitis, acute pancreatitis, because surgically you can't do anything. What you have to do, number one thing, nil per order. The patient should not give anything, even water, should not take anything. Because you take anything, the pancreatic enzymes are released, they are more coming into the area, so you should go for IV treatment, you should control his diet, you should control his pain, you should control his fluids. If you monitor conservatively, the patient may be alright, maybe steroids for inflammation and other things, the patient may be alright after 2 weeks like that. But if you make very heroic effort to let's see what is inside, and you find pancreatitis, oh, I have given a death certificate to the patient. Okay? So this is a lesson that for pancreatitis, especially acute pancreatitis, surgery is not used.
Then how should I know what's the problem?
Yes, you should use the ancillary techniques, CT scan, MRI, with a good and important investigation. If you have an amylase level so much raised, why you should not think about it? Okay, there is no pancreatitis. Maybe chronic pancreatitis can have
Yeah.
normal amylases.
Doctor, you said in chronic, the amylase and lipase, it's the same. There is no elevation.
No, in chronic
So-
also there is elevation.
Just 24 hours or 48 hours.
That is for acute. That in acute pancreatitis, certainly there is elevation within first 24 hours, and in afterward the amylase level remains high. It is not going down. But the lipase test is more significant at that point, after 24 hours. It doesn't mean that amylase just comes back normal. In chronic pancreatitis, it is also elevated. But it is not elevated to that level as you see in acute pancreatitis. For in acute pancreatitis, it could be up to 100, up to 1000. But in chronic, it could be 20, 23, 24. Instead of 10, it can be a little raised. So then you should have some suspicion about it. Then in CT, you will find these calcification, or you will find these pseudocyst formation. So you should suspect it is a patient of chronic pancreatitis. We should not go for surgery. Because if you cut it, all the enzymes will leak into the abdomen and then again cause a very huge problems. So the complication, there is severe pancreatic exocrine insufficiency leading to malabsorption. There could be secondary diabetes when this is also damaging the islet cells of Langerhans. It can lead to pseudocyst formation, and even rarely it can be associated with pancreatic cancer. So chronic pancreatitis can lead to damage and fibrosis, and ultimately some of the pancreatic epithelial cells become atypical, leading to pancreatic cancers. So what are the pancreatic neoplasms which are suspected? It could be serous, mucinous, microcystic, intrapapillary and then malignant pancreatic adenocarcinomas, where you find a lot of sclerosis or artery. Dense sclerosis as the rule means in always pancreatic adenocarcinoma, you will find severe fibrosis, severe hardening, severe sclerosis, excessive marked sclerosis. So these are the classification. In the serous, which is actually 25% of all pancreatic cystic neoplasm, you will find a lot of small cysts. They are glycogen rich cuboid cells which are surrounding the small cyst. So all these cells which are lining here, they are very much glycogen rich, and then inside they are filled with clear straw color fluid. It is more common in the 7th decade of life, and females are slightly more than males, and it is always benign. Okay, so
What's
serous
straw color?
straw, you know, it is light yellowish, more than water, not very thick. You know, some mushroom, they are like that. Then you will find a little yellowish color. That is called straw color.
Doctor,
Thank you.
seventh,
Yes.
seventh this decade.
7th decade of life.
إيش هذا؟
70.
ايش هذا؟ 70 70 the 7th. Okay. So mucinous cyst adenoma. Mucinous means it is lined, it has multiple cysts which are actually filled with jelly-like material, mucin-like material. No talking jihad. Now I have to,
Distribute.
please, come. More, kathir. Yes, it should be separate. One's talking here, one's talking here. Okay, so mucinous cyst adenoma. This is very common. 95% of the mucinous cystic neoplasm, they arise in women. So in females they are more like serous, but they are also more common in females, usually in the body or in tail of pancreas, but usually not the head. It is filled with thick, tenacious mucin. You can see in this cross picture, somewhere it is very thick mucin, like jelly-like material. And the cysts are lined by columnar cells, which are filled with having apical mucin. So all of them, they are having a lot of apical mucin at the apex of these columnar cells. They are usually low grade. It could be sometimes moderate mucinous atypia, and very rarely mucinous cyst adenoma can be having severe dysplasia. Then it becomes mucinous cyst adenocarcinoma at that place. But usually it remains benign, but it can be borderline or moderate, or it can be adenocarcinoma even. Then the pancreatic adenocarcinoma. 4th leading cause of cancer death in the United States. 4th leading cause of death. The first leading cause of death is which cancer?
Lung cancer.
The second leading cause of death? Prostatic cancer in males, and in female breast cancer. Then the third is GIT in colon, and the 4th one is pancreatic. In US, in some other countries, because the consumption of alcohol and these things, they are major factor there, so they are more prone to having this. So 4th leading cause of cancer death in United States. The 5-year survival rate is dismal, it is less than 5%. So you can see only 5% people, they survive up to 5 years. 95% of the person after diagnosis of pancreatic carcinoma, they die before 5 years. So that's why it is worse prognosis. Age is commonly involved 60 to 80 years. Smoking, again, very common
Double the risk.
So it can increase or double the risk. Chronic pancreatitis and diabetes mellitus, it can be associated with this. So some people who have chronic pancreatitis, this can cause a lot of damage to the pancreatic epithelium. Some of the epithelial cells, when they become, regenerate, they become atypical, got mutated, and then we can see a lot of chances. What is the relationship? They say that sometimes there are multiple mutations. Like in GIT, we know that a normal GIT colonic epithelium can change into colonic adenocarcinoma by multiple mutation, by, for example, KRAS mutation, telomerase mutations, and P53 mutation. The same happens to pancreas. That there is sometimes telomerase shortening. So the normal epithelium, pancreatic epithelium, can become changed from pancreatic 1A condition. It is a little atypia, some more atypia. Here it is like sin 1, sin 2, sin 3, as we see, maybe I think we will discuss next year, about cervical intraepithelial neoplasia. So this is the severity of the dysplasia. Some dysplasia, some atypia, more atypia, and highest atypia. But still there is no invasion. But once it gets more mutation, like P63, SMAD4 or P53, then it becomes invasive carcinomas. So this is the stepwise pathogenesis. So precursors are intradactyly papillary nuisance neoplasm, we discussed before also. So from these neoplasms, it can be progressed to become invasive adenocarcinoma. So pancreatic intraepithelial neoplasias, it can have these mutations which can be seen here. Smoking doubles the risk, and chronic pancreatitis and diabetes mellitus can also be associated with the pathogenesis of this pancreatic adenocarcinomas. So the gross, we see that this is the area. It is usually 60% in head and 15% in tail of pancreas. Hard, grey-white, stellate, poorly defined masses. You can see a lot of star-like or poorly defined masses. You don't know where it is starting, where it is ending. And microscopically, it is highly invasive. And as I told you in the start, that the fibrosis, excessive sclerosis or hardening is the rule which you will see on microscopic examination. So everywhere there is fibrosis except few areas where you find some glands. So this pancreatic adenocarcinoma has excessive desmoplasia. The word desmoplasia again means high fibrosis, excessive fibrosis. Carcinoma head of the pancreas obstruct the distal common bile duct. So usually it presents with jaundice. Why? Because once the bile duct is blocked, so the back secretion of the bile, so it can lead to leakage of this bile into the surrounding area, and a person can be severely jaundiced. And it can, yes, usually complicated, pancreatitis. Carcinoma of the bottom cave remains silent for a long time and widely spread at the time of diagnosis. Okay, so this is the differences between different types. So the fate means what is the outgrowth? It can go into regional lymph nodes, maybe into celiac lymph nodes, maybe into the nearly hepatic lymph nodes, or into the iliac lymph nodes, can go into the liver, can metastasize into the spine, can go into the lungs. Metastasis can happen in this way. So the grading of this can be done by the well differentiated, moderately differentiated, or poorly differentiated.
Is that doctor? Oh, grading.
Okay, and the staging can be used by TNM, tumor stage, lymph node status, and metastasis. Then the final tip of the day is that most pancreatic cancers are diagnosed at an advanced age, so the age will be older, accounting for the high mortality rate. Again, with old age, the immunity will be less, the proteins will be less, so a person's ability to cope with the disease will be less, so mortality is higher. Obstructive jaundice is a feature of carcinoma of the head of pancreas. Okay, obstructive jaundice means conjugated. So many patients also experience debilitating pain. They can associate it with a lot of pain. Painless jaundice in an elderly person is carcinoma of the head of pancreas. Painless jaundice. Usually, if a person comes with a jaundice which is having no pain, but the jaundice is increasing without any pain. So in an elderly patient, in an old patient, then we should suspect that this is carcinoma of the head of the pancreas. Yes.
How the first one there is pain?
Yes, they say many patients can pain a pain which is not related with the local pain. It is the debilitating pain. What is the debilitating pain? You have seen any cancer patients? They will be very much cachexic. They will be very thin and lean, like bones on the, like skin on the bones. These kind of patients actually they are having pains which is generalized pains, not the pains which are typically at the level of the pancreas or at the abdominal level. Okay, so this pain is because of excessive malabsorption, excessive debilitation in the body. Generalized. So some neoplasms they are also in the endocrine pancreas. For example, it could be the beta cells, then it is called insulinomas, which are common. Alpha cells called gluconomas, and the delta cells they are called somatinomas. Out of these, islet cells are very common. About the beta cells are very common. So gastrinomas, you know about that. Gastrinomas may be present in the stomach. It may be present in the pancreas. It can be present in the duodenum, and they secrete a lot of gastrin, which is a stimulant of pepsin. So these patients they are usually presenting with a lot of ulcers, peptic ulcers, because of this excessive secretion of gastrin from these tumors.
Again,
and
Dr.
this
again.
is called as Zollinger-Ellison syndrome.
Again.
Chronic gastritis.
So those people who have gastrinomas, which are endocrine tumors, they secrete a lot of gastrin. Gastrin is a stimulant of secretion of the stomach, for example, pepsin and HCl. So excessive HCl and pepsin will digest the cells of the stomach
Yes,
itself,
of
leading to
course.
peptic ulcers. So this is called as Zollinger-Ellison syndrome, okay, which is caused by gastrinomas. The insulinomas, they are commonest type. There is presenting with hypoglycemia usually because the excessive insulin will digest any carbohydrate, any sugar. So the level of sugar will be very low. This is one of the findings, less than 50 milligram per deciliter. Attack is precipitated by fasting or exercise. So those people who have insulinomas and they suddenly go for fasting or they suddenly go for some exercise, so all the glucose which is present, it is used to be consumed during energy, during protein production, during energy production. So at that time, the attack comes. So they go to hypoglycemia and they end up into shock. So laboratory, there will be decreased serum glucose and there is increased serum insulin. Obviously it is insulinoma, so there will be more insulin here. Most tumors in pancreas, but it can be ectopic, for example, in some other places. Most tumors are single and they are less than 2 centimeter, can be multiple. Majority are benign and 10% can be malignant. Mostly they are benign. Histologically, it is very difficult to diagnose malignancy or pancreatic cancer.
Doctor, insulin, the insulin gonna be rise?
Raised.
Raised.
And when the insulin is raised, the glucose has decreased.
Of course, yeah.
So the gastrinomas, I already told you, it's more in middle-aged females, located in pancreas, duodenum or peripancreatic tissue, maybe single, maybe multiple. And they are sometimes more than 50%, they are invasive into the surrounding area, locally invasive. And they have metastasized at the time of diagnosis. They present with a syndrome which is called Zollinger-Ellison syndrome. And I told you the reason.
Yes.
Because of excessive gastrin, excessive HCl, excessive pepsin, and excessive ulcers.
Damage the cell.
Peptic ulcer disease, ulcer will be multiple, unusual location, for example, in the jejunum, and the pain is intractable. There is a gastrin hypersecretion and there is diarrhea in more than 50% of the people. So usually they present with diarrhea, severe diarrhea. So this is it. We will finish with this. So there is insulinoma, which is important, and the gastrinomas among the endocrine tumors. And in the exocrine tumors, you should know about pancreatic adenocarcinomas and serous
We took it in
tendons.
no
Yes.
block digestion.
Tendons.
Chronic gastritis.
Thank you very much, Doctor.